So I'm going to do what I did before because I'm blind as a bat at times, so I apologize. Yeah, so should we be intervening on asymptomatic carotid artery disease? The sands are shifting. I could call myself Ross Naylor, but I won't today because I have somebody else who I'm going to co-opt on in a few minutes. So no disclosures. So in the old days, asymptomatic carotid disease often was framed based on studies from such studies as the cardiovascular study in the fragmenting cohort, and it really showed that the disease does exist, that these people have a significant stroke rate, and that they are at a significant risk for additional cardiovascular events. Biologically, that makes sense, since the carotid artery arises from the same mesodermal smooth muscle cells as the coronary events, and so that link made sense. The early trials, those done in 1985, and even the one reported in the Lancet in 2004, would have shown that for carotid endarterectomy, in general, the rate of stroke during the procedure was about 2.3 to 2.8%. The genesis of the American Heart Guidelines, which still are commonly talked about for asymptomatic disease, used 3% as the rate at which one would consider that the surgeon is truly competent, and that anything up to that rate, it's fine, you can go ahead and do it. Those 5-year risks are that they saw in their studies were markedly superior to those that might have been considered for best medical therapy. And so based on this data, it's quite convincing to say that the use of best medical therapy is completely inappropriate for an asymptomatic disease. Now, this is presumably that your surgeon is competent and he stays below 3%. The CREST trial demonstrated many things, caused many controversies, but what it did show is people are getting better. And now, in competent hands of people chosen for that trial, that stroke rate's 1.4%. That's great. We've done a really good job. The SVS registry, which would include people both in and outside the CREST trial, is also convincing that the treatment for asymptomatic disease and the rate of stroke around that procedure is markedly reduced, and now we're down to about 2%. But nationally, we still say 3% is the mark. When you look at the world, and this happens to be a New England Journal paper in about 2008, so yes, a little dated. If you go to Europe, I would suspect that the diagram is somewhat more shifting towards best medical therapy. But in general, about 50% of asymptomatic carotid artery disease is treated medically. The remainder is treated by an intervention of one description or another, whether it's carotid stenting or a carotid endarterectomy. And that medical therapy is aspirin, antihypertensive therapy, lipid-lowering agents, tobacco cessation, and nowadays, significant control of your diabetes to get a hemoglobin A1C less than 7. But as the biology of humans changes, so does their chances of having problems. And so in a study looking at the best medical therapy for secondary prevention in stroke trials, and this is the genesis now of anybody having a stroke center where aggressive statin therapy is a prerequisite for you to get your certification, stroke is dropping. So in the old days, it was 8.7%. Now, the recurrent stroke rate is about 4%. If we look at either ipsilateral or any strokes, for medical intervention with stroke in the presence of an asymptomatic artery, it's dropping significantly. This kind of mirrors the stuff that we saw with stents and lesions, but it's better in the sense that we, as a population, are making a difference. We are controlling some of this atherosclerotic burden, both for an ipsilateral stroke if you have your asymptomatic disease there, but also for any stroke. If one puts all the trials together, really the rate's now down to less than 1% for best medical therapy. And in the more recent trials, it's probably under 1%. And we're talking about something between 0.5 to 0.7 in a perfectly controlled trial. So we have asymptomatic carotids at either 2.4 or 1.4%, but best medical therapy at 1%. So I had a mathematician who was one of my patients, and he brought me in 50 pages of his differential calculations to prove to me that I shouldn't be touching his 80% stenosis because he had all the data. This is just a redraw to make it much more plain from Ross Naylor's work in 2011, showing this marked drop that's occurring. Now, Yesterday, Claudia pointed out that in CREST 2, you would be looked after best medical by a health coach. So our health is a very small entrepreneurial company that goes into specific markets and offers concierge medicine. And one of the big things they do, in addition to what Jeb talked about, which was telehealth, is they have health coaches. Now those health coaches are not doctors, they are not nurses. Does anybody have an idea what kind of health coach the substrate for that health coach is? They are bartenders. And the reason is, bartenders can talk to anybody for a long time. Now, whether they sell them red wine at the same time, I don't know, but they're effective. And this group gets 150 to 200% improvement in health compliance compared to anybody else in the territory. Ross Naylor published something more interesting, looking at all the trials. The bubble, if it's blue, would be carotid, red is a stent. The size of the bubble reflects the number of people in the study. And he demonstrated that, yes, indeed, a lot of people are dropping below 3%. But if you take 0.7% as perhaps the best medical therapy that we're currently seeing, a lot of those trials are much higher. A similar pattern will be seen if you took symptomatic disease. Again, many trials are above the line that the AHA set a long time ago, which was 6%. Now, I looked for someone who would either contradict or not contradict with me, and I found this on Medscape. Some of you may recognize the character, some of you may not. This character said the idea of operating on every asymptomatic carotid stenosis of a high degree is really, in my opinion, and again, it's my bias, indefensible. There was no adversity there. That's pretty clear. And in his opinion, is that to treat, we should be treating most asymptomatics with best medical therapy, not intervening on most of them. It runs for 9 minutes, but these are the key points that I took out of the transcript. But even if we look at the guidelines between the two large societies, the SVS and the ESVS, we still do not have unanimity on what we would consider successful. And poor Bob Swolak, when he went to Copenhagen and he stood up and defended the SVS guidelines, he did not end up as happily as Dr. Veith did by getting fired. Dr. Swolak ended up with no arms and no legs because he got gutted. And he got gutted because they said you're promoting the procedure and not the patient. The American College of Cardiology rates treating on asymptomatic disease at 1C. There are 26 separate guidelines in the world on who should treat what, when, and where. The more writing on the slide suggests that there's more conflict rather than unanimity, but still people believe that they should still go forward, but nobody sets a lot of guidelines as to what you should be doing. But we can predict stroke in asymptomatic carotids. This requires us to go beyond our standard angiography, to go beyond just the regular duplex. If one takes TCD, and this does not have to be terribly sophisticated, but like an MCA-based TCD on the ipsilateral side, and one finds microemboli coming from that, then the chances of having that lesion currently or subsequently becoming asymptomatic is quite high. And it can be it's 10% with MESs, the microemboli, 90% without. So we can definitely adjust our thinking. We can look at cerebrovascular reserve, which refers to the capacity of the brain to increase its cerebral blood flow, to maintain a constant regional blood flow and in the face of a low cerebral pressure. And in the various studies that have looked at that, there's a 5-fold increase if that cerebrovascular reserve is altered, which may also help you and point you towards the need to intervene on the asymptomatic carotid. Much work has been done on the type of plaque that's present. A lot of it's based on echolucency or the potential for rupture. But in essence, one can see that in patients who have low neovascularity, low infiltration, less elastin or collagen, which I'm not sure how you do that without taking the plaque out, but that's a separate issue, less calcification and less cellularity, those people are highly likely to be asymptomatic. There's also contention that if you aggressively treat them with statins, so to get them onto a rabbit diet with an LDL less than 70, they may actually see some regression. It could be up to 1.4-fold. And so this also begs the questions about what should one do. And finally, there are many markers, both serum-based and based on creatinine, that may suggest also that the carotid stenosis is not as stable as it may appear to you and would prompt you to actually go forward and intervene on an asymptomatic carotid. And then finally, if there is stenosis progression, those people do have a higher rate of an ipsilateral stroke, and that it makes significant sense for moving forward. So there are many things that are out there. The first one is that ACA and ACST are historical, and I've shown you that the rates that are quoted in those trials and the rates out of CREST are markedly different, and we have got significantly better. Even if you operate on every patient who has asymptomatic disease, it will not cure 95% of the strokes in your community. There is actually one study in Circulation about 10 years ago. They retrospectively looked through all the records. They were not a RAC organization, thank goodness for the particular facility. And 50% of the asymptomatic carotids that were performed fell out of any criteria that I've shown you today, which is a significant issue. The U.S. Preventive Task Force does not recommend screening. AHA never really talked about what is a highly selective patient. I've tried to give you a little insight into what might be suitable for that. The rate has to be reduced to 0% for 93% of all interventions to be ultimately unnecessary. But there is this definitive decline in embolic stroke, and it's evidence in all the randomized and non-randomized studies. But CREST-2, whether you buy it off the shelf or you indulge in the therapy, may well answer these questions, with or without the proviso that Claudio added yesterday, which was that they are going to have health coaches. But in essence, at the Dell School of Medicine, they've decided to teach every medical student to be a health coach. So because they do 72 hours plus of classwork a week and another 100 hours plus of work on the online, every single medical student has a minder who's their health coach for 2 years. And this is to ensure that they, one, don't cut their wrists, two, they don't try to flee Rochester when it's warm, because they know they can keep them when it's in the winter. And three, because they truly believe that that's where the medicine is going. We'll all have health coaches, whether they're electronic, like Jeb talked about, or whether they're real people. Thank you, and I'll take questions towards the end.